thank you for taking the time to do an interview for ArborMed. Perhaps we can start with your name and your job title and position and affiliation.
Good day. My pleasure to be here. Name is Mike Schilsky. I'm professor of medicine at Yale University, and I'm the director of Center for Excellence for Wilson Disease at Yale as well.
And your affiliation or association with ArborMed?
I became interested and learned about some of the seminal work of Dr. Hans Zischke a number of years ago, and I've been following that. And I had the great pleasure of having the opportunity to now serve in an advisory capacity, both scientific with the aim of more moving this towards clinical production for this compound.
Can you please, to the best of your knowledge, describe ARBM-101 that ArborMed is developing, and in your opinion, what really makes it a differentiated therapy?
Well, this compound is really unique. First, it is a small molecule, and it's also non-immunogenic, and that means that you can give it and then not develop a reaction from it. And so that is highly favorable, because then you have you would predict a much better safety profile. But the unique aspect of this is, unlike any of the other available therapies now, this has the capacity, at least shown in the preclinical studies, to reduce the copper in the liver, to restore the balance of the copper, and allow the mitochondria, which is sort of the powerhouse where we generate all our ATP, which is the basically our cellular batteries that allow our cells to have the energy and function, and allows the restoration, and miraculously doesn't seem to pull copper out of other places where it's needed for metabolic function, things like cytochrome enzymes, which allow us to then process and move electrons along and develop other utilization of energy in the cells, doesn't seem to be impacted. So by giving this compound, and it's been shown in the animal models, the liver injury that has occurred from copper can actually be abated tremendously, and you see a restoration not only of what we call the histology, how the liver would look under a microscope when we take a piece out and then process it and look at the cell structure, but also the ultrastructure, which is the mitochondria itself. The injury pattern, which you can see that copper may cause, actually can be reversed. The production of energy by the mitochondria can be improved, and you can measure the production of free radicals in cells, and that also has been improved. And so the more recent data on this suggests not only do you reduce the copper, but you're actually sending it out by the pathway that naturally occurs for copper in the liver, that the excess goes out into bile, and then that's an exit from the body. So we're actually have an understanding that you're taking the copper, not putting it back in the bloodstream where it may go to other organs, but putting it into the bile where it can then go out of the body, and that could be a safer way of removing copper and giving the chance for the liver to heal and restoring the balance in other organs as well.
And what role do you think ARBM-101 could play in the treatment paradigm of Wilson's disease, and how it could be most effectively used if the results to date hold true in human studies?
Well, I think there are many different applications at different stages of the disease. One of the things we put forth in that guidance for the American Association Study of Liver Disease was to think of treatments in phase of disease. So early on you want to prevent disease. So if you use this compound very early, you would then deplete the copper from the liver, or at least the excess copper from the liver, and then prevent the development of disease. If you start with symptomatic patients, you can then provide a sink by reducing the copper in the liver, so the natural pathway for flow of that copper can be restored, and you can create a buffer and a pull for copper from the extrahepatic sites, notably the neurologic system, and that may be a very powerful thing. And in fact, sort of a proof of principle that that really has potency is if you look at the model of liver transplant, where you restore a normal liver function and normal biliary copper excretion pathway, we see obviously a transplanted liver, but we then also see improvement in neurologic or mental health aspects of the disease if it hasn't been present too long and irreversible damage has occurred. So in many patients, we can restore function. Now, the other exciting part, and we learned from some of the studies on the choline tetrathione from the phase 3 studies, that even patients who've been treated with standard of care chelators have copper that can be pulled out by stronger chelators. And so I think that even in patients who've had a partial response to therapy on standard therapy, there may be the ability to use this compound to see if we can augment and make that improve even further. We know that at least in 30% and sometimes even up to 40–50% of patients on therapy may have abnormal liver tests as well, and this may be a harbinger over time that liver injury may occur and then scarring can progress. And again, I think by restoring and reducing the copper in the liver, I have a feeling we're going to be able to show that those patients will benefit in the long run as well. We'll be able to restore their liver enzymes back to normal, hopefully prevent fibrosis progression as well.
And ultimately, all these potential benefits would improve the lives of patients. And what do you think will be the most meaningful improvements in these patients' lives?
Well, I think the important thing is we're going beyond survival for patients. We have some therapies already to help with that, but I think restoring the quality of life, and quality of life comes in many different aspects. That includes the ability, again, to reverse injury, but also the ability to make it easy for patients. And so if they don't have to take a daily medication multiple times a day, and if they have a buffer and a large amount of capacity for copper, maybe they can even eat a little bit more generously of some of the foods they may otherwise love. And so I think we can improve not only the disease itself, but their quality of life. And I think that's an important aspect that we hope to achieve.
And ultimately, as clinicians, that is our goal, right? To improve the quality of life of patients. Well, thank you so much for this kind interview, Dr. Schilsky.
My pleasure, and I really look forward to the clinical development for this compound, and thank you for the time to share this with you today.